I'm Dr. Hasan Sheikh. I'm the Vice Chair of Canadian Doctors for Medicare, and I am a physician based in Toronto. And I'm very excited that you are all here today joining us on this webinar about the future of virtual care in Canada. The pandemic has drastically changed the landscape of virtual care, and we've seen a rapid expansion across the country. And in many cases, that has led to innovations in access and our ability to provide patient-centered care during the pandemic. But there's also a significant potential dark side of virtual care. And the rapid expansion has been accompanied with a rapid acceleration in the corporatization of healthcare across the country. That's why here at CDM, we think it's critical that we host this discussion tonight and delve deeper into the issue of virtual care and how we might deliberately design a system that really fits with our values. And so we thank you for being here with us today. For those who are new to CDM, we're a nationwide, evidence-based, and nonpartisan organization that is dedicated to preserving and strengthening Canada's publicly funded healthcare system. We advocate for innovations that are evidence-based and ones that in particular improve access, quality, equity, and sustainability. And on the topic of equity, we want to start by recognizing the significant and unjust health disparities that Indigenous people continue to face today due to systemic racism and the effects of colonization. We hope to work towards reducing these inequities as we continue to advocate for a better Medicare. And we acknowledge that the CDM office is located on the traditional territory of the Wendat, Seneca, and Mississaugas of the Credit. Now, if you're a medical student, resident, or physician and not yet a member of CDM, please consider joining today so that you can stay engaged with us on topics that are important to Canada's healthcare system, like virtual care and pharmacare. We'll add a link in the chat box so that you can become a member. Now, we have two great panelists tonight, and I have the pleasure of introducing them to you. Dr. Sheryl Spithoff is a clinician investigator at Women's College Hospital and an assistant professor at the University of Toronto. Her research focuses on access to care for people who use substances and the impact of commercial interests on health and the healthcare system. She recently published a fantastic article in the Globe and Mail on virtual care with Dr. Tara Kiran, and we will link to that as well in the chat. The article was certainly eye-opening for me, and I'm looking forward to delving a bit deeper into the context around virtual care and where we go from here. So welcome, Sheryl.
Thank you. Thanks so much for having me.
Our second panelist is Karen Palmer, who is a healthcare policy analyst and a health systems research for 3 decades. Her passion is anchored in the equitable access to high-quality care. She was raised in Canada, but Karen also lived in the US for 22 years, including in California, Hawaii, and Utah, before returning home to Vancouver in 2006. She holds 2 graduate degrees from the University of Hawaii, and she is an adjunct professor at Simon Fraser's University's Faculty of Health Science in Vancouver. She serves as a policy advisor to the Physicians for a National Health Program in the US and to the Canadian Doctors for Medicare in Canada. And she collaborates with researchers and advocates, activists in Canada and the US, in Europe, and provides expertise on healthcare reform. Welcome, Karen. Oh, I think you're on mute, but that's okay. We'll come back to you when it's time.
Do you think after 1.5 years we would know this? Thank you. That's a lovely introduction. I appreciate it.
My pleasure. So in a moment, we're going to turn things over to Sheryl and Karen and set the scene on the current state of virtual care and how it's expanded and evolved throughout the pandemic and what it means for the future of Medicare. We'll then move on to the Q&A, and as Katie mentioned, that part will not be recorded, and those will be questions that you as the audience provide in the chat box, or you could raise your hand and use the raise hand function. So Sheryl, let's start with you and your excellent article, The Dark Side of Canada's Shift to Corporate-Driven Healthcare. It really set off alarm bells for me about some of the insidious and frankly not so insidious ways that our system is changing, and the revenue generation that has become kind of the high priority over health outcomes, and the fact that our health data is now becoming a financial asset. Could you take us through your article and dive a little bit deeper into the current state of virtual care and some of the dangers of unregulated corporatization?
Yes, thank you. I'm happy to. So thank you for that introduction. Tara, Karen, and I wrote this article because we had noticed an increase in the corporate expansion into health services, particularly into primary care services, seemed to be driven by the pivot to virtual care during the pandemic. So we wanted to explore what the implications were for health system costs, for the quality of care, and then also, as mentioned, for patient, the privacy of patient data. So the expansion is not new. It's been going on for decades. Corporations have been buying up mom and pop pharmacies, small chains of pharmacies, also physiotherapy clinics, purchasing companies that produce electronic medical record systems, and then more recently investing in wellness apps and virtual care platforms. An example of this that some of you might be familiar with is Loblaws grocery chain. They also own the Shoppers Drug Mart pharmacies, and as well as Accuro, QHR, the EMR, which is the EMR of the second largest market or share of the market in Canada. And more recently investing in wellness apps and purchased a minority stake in Maple virtual care platform. So with the pandemic, virtual care took off. The governments issued stay-at-home orders. Physicians were looking for ways to still provide essential services while keeping their patients safe, their staff safe, themselves safe. And government started funding virtual care. So pretty much across Canada, governments overnight started paying for these services. And yeah, virtual care took off. In my practice, we went from 1 week, maybe 10% of our interactions with patients were virtual, mostly phone calls, some email communication. And then Monday, the next week, more than 50% of our interactions were virtual. This seems to be how things are, or how things were at least across Canada. A study from Ontario found that in the early days after of the pandemic, about 70% of visits were virtual. And this was a real change for people in Canada. We'd had very little access to virtual care prior to the pandemic. Wasn't because of a lack of interest or demand. A survey conducted not too long before the pandemic started showed that 7 in 10 Canadians wanted to have virtual communications with their providers. 4 in 10 would have preferred that most of their interactions be virtual with their providers. But there were barriers, funding barriers, complicated system requirements, clunky systems, and it wasn't happening prior to the pandemic. But out of the pandemic emerged 2 different models of virtual care. One is virtual care that's integrated into ongoing primary care, and this is probably what most Canadians are familiar with. But there's also another model where patients log into a commercial virtual care platform through an app or a website, and then receive care from a provider with whom they do not have an ongoing relationship. This is often called standalone virtual care or walk-in clinic style virtual care. Now, whether or not you have to pay for this, the second model, depends on where you live in Canada. In the provinces of BC, Alberta, and Ontario, it's funded through the provincial system. Other provinces, it's not. PEI also funds it in a limited way right now. They pay for commercial virtual care services through the Maple platform for people who do not have a primary care provider. So why are people using this particular model, the standalone virtual care? So yes, convenience, but there's also real gaps in our system. A large, or about 15% of Canadians do not have a primary care provider. Even the ones who do, some of them, or a significant number of them, have long wait times. A survey conducted not too long before the pandemic started showed that less than 50% were able to get same day or next day appointment for an urgent issue. And I think about 1/3 were able to get appointments on evenings and weekends. The rest were not. no access out of country because of physicians don't have liability protection for providing services if someone's on vacation or traveling outside of Canada, and then also poor access to mental health services. And what about for our companies? Why are they so interested in providing virtual or standalone virtual care? So one thing is better margins. They don't have to, if they only provide the standalone virtual care, they're not paying for the physical clinics, they're not hiring staff, they can scale up and down, they have more demand, they can increase the number of shifts available for physicians, and then they can decrease that as the demand goes down. They also tend to provide care for low acuity problems. So anything more complex goes back to the family doctor, to a physical walk-in clinic, or to the emergency department. They typically don't provide preventative care. For those of you that work in primary care, you may have an appointment with a patient for a sore ankle or something like that, and that might take up 5-10 minutes, but then you're typically spending a few more minutes at least reviewing their chart, seeing if they're up to date for their screening, seeing if they've had recent blood work, checking in about their mental health. Whereas these services typically wouldn't be providing that because they're not providing ongoing care to the patient. The other thing is user fees. So for the platforms that are outside of those provinces with provincial coverage, they typically bill patients, and they can essentially bill them what they want, what the market will bear. And even within provinces where these services are funded, some of the commercial platforms also bill patients in addition. So they'll bill a fee for like a monthly fee for being registered and being able to access the provincially funded services, kind of like the executive clinics that bill a fee if you want to go and see a physician there, even though the physician bills OHIP or whatever province you're in bills for those services. And then additional payments. So in PEI, something interesting has happened there. So Maple has a contract directly with the government. So the government paid Maple a $30,000 setup fee. They also pay them a monthly licensing fee, and then they also pay them fee for service payments for the virtual care service there. So there's other opportunities to make money as well. And then many companies are looking, because they're large corporations, they have different business interests, or looking to see how virtual care can also help out and promote their other businesses. So for example, the corporations that also own pharmacies, they are placing kiosks in their pharmacies. So they drive foot traffic to their pharmacies to rapidly access a physician who can renew a prescription for a patient. And it goes the other way around, of course, too. Also wellness apps, these are often linked together with the virtual care platforms. Now there's other opportunities as well that some companies seem to be interested in. It's a bit unclear exactly what's happening in some of these areas, but they get access to patient data. And there's very strict regulations around what you can do with personal health information, but if it's de-identified, currently in Canada, there's no laws controlling what you can do with that data. There's already a walk-in clinic, or there's already an international data broker who has about 1 million patient records from across, de-identified patient records from across Canada. And one of the companies that offers virtual care services says it also intends to get into this market. A couple of others have big data listed as something that is a potential revenue stream for them. This data is, even though it's de-identified, you would think it wouldn't have much value. It actually does. Pharmaceutical companies are the ones who are interested in the data. Sometimes it's also used by researchers and governments. And then the other thing that's come up is partnerships with pharmaceutical companies. One of the virtual care, or one of the corporations that provides virtual care services, recently purchased a marketing platform. So it's essentially a platform that has educational materials created by the pharmaceutical industry for physicians and for patients. And this corporation is planning on incorporating that platform into their electronic medical record system that physicians use when they provide care virtually or in person. So this is a new model in Canada. I haven't come across it before, but it's actually not uncommon in the US. There's a number of electronic medical record vendors that give physicians their systems for free or heavily discounted if they're willing to have advertisements within them. Some of you may have heard of Practice Fusion. So this is a company, an EMR company in the US that did that, but they went a few steps further. They took money from Purdue Pharma to put prompts within the EMR to encourage physicians to prescribe more long-acting opioids, OxyContin. Were caught, both companies were fined, but who knows what goes on. So what are the risks? The standalone care, this has been written about in a number of places. There's concerns that it leads to fragmented care, as people are just like walking clinics are getting episodic care, they're not getting their ongoing care needs looked after, might be missing out on preventative care. And also there's concerns about equity issues, who's accessing the standalone care. Data from the UK indicates that it's younger, healthier, wealthier patients that are using these services, getting rapid access to physicians. Other people are having to wait longer. Also concerns that services might be duplicated if something is too complicated to be managed virtually. Instead, it goes to a walk-in clinic or back to the family doctor or to the emergency department. So health system costs there. And then, of course, the concerns with the other business practices, selling patient data or commercializing patient data. There's privacy risks with that. Even if the data is de-identified, there's still risk of re-identification in the data sets. The other risk is how the data actually gets used. And it seems to be primarily used by the pharmaceutical industry. One major use they have for it is marketing to physicians. Across Canada, except for in a few provinces, physician information, your information is actually identified in there. So they're able to track you and track your prescribing habits, market to you, and see what kind of impact that has on your prescribing behavior. And marketing to physicians has been associated with poorer prescribing habits, increased prescribing costs. Less physicians who interact with pharma are less likely to follow guidelines. And then the bigger picture, what happens when there's increased corporate delivery of health services? What kind of impact might this have? So we know in general, I mean, corporations, they're large, they have shareholders, their responsibility is to increase profits for their shareholders. So that means increasing revenues, cutting costs. And the way they go about that does not necessarily align with the goals of a public health system. So one example that comes to mind is PEI. The goal of a public health system there would be to connect as many people as possible with a primary care provider. However, that cuts into Maple's business profits. They're profit because there's fewer patients then who would be using their virtual care services. So what's going to be the outcome of that? And in general, we know that when there's for-profit corporations that are delivering care compared to nonprofit public, that the costs tend to go up, quality tends to go down. We've looked at hospitals, dialysis clinics, surgeries. The other issue, of course, is cherry picking patients. They tend to find ways, very interesting ways in some cases, to get the healthier patients using their services and making sure the less healthy patients stay in the public system. So virtual care can be a very important tool. It can help us provide effective, equitable healthcare to our patients. However, the commercial virtual standalone method of providing virtual care is likely to lead to fragmented care, increased health system costs, has other implications as well, business practices that may cause harm and conflicts and goals. So in our article, we made a few recommendations, Tara, Karen, and I, about what we thought might help to address some of these issues. So improving access to primary care. One thing we could do there is expanding the team models of care. So these are models of care where physicians work with nurses, social workers, physiotherapists. They're more expensive up front. They do provide higher quality of care, and there's indication that they actually lower costs overall. because of the better quality of care that they provide. And their ownership is also limited, or who runs them is also limited typically to physicians or nurse practitioners, or for some of them to community groups. They can't be owned by a private for-profit corporation. And then key here is requiring that these clinics, these practice teams are responsible for patients in a geographical area. So I don't know if anyone has looked at the Price-Baker report that came out some years ago, but this is one of their key recommendations, that we need to have some kind of system where the primary care system is responsible for patients. So if you live in a geographical area, you can have a physician in that area. And this would go a long way to improving quality of care for people, and also decreasing the demand for the commercial virtual care services. Better integrate virtual care into ongoing primary care. Stop funding the commercial standalone virtual care. I mean, this has to be done carefully and thoughtfully, because there are people that depend on these services now that don't have a primary care provider. What are they going to do if these services are no longer funded? I mean, some provinces haven't started funding them, so they're not in that situation. But maybe there's a way to integrate, at least temporarily, until we have better coverage, primary care coverage for people, integrate it perhaps into the provincial telehealth services. I think Ontario did try this initially at the start of the pandemic, but I don't think it was successful. I think, from what I understand, although I haven't looked into it, is it was just kind of drowned out by all of the other commercial services out there, and it just didn't get a lot of uptake. I don't even know if it still exists. And then, of course, prohibiting the harmful business practices. So there is, the federal government did table a bill to limit what you can do with de-identified data, to put more controls over it. I don't know if it's going to go anywhere. And it doesn't place restrictions on internal use. Now, these corporations are getting very large, and a lot of the ones that gather data could potentially, I mean, they also own pharmacies, they could potentially also use these data in ways that are problematic, even if they're not selling it to an international commercial data broker. And then banning advertising within the electronic medical record. I don't know how this could be made into a law, or because there's no restrictions right now on pharma advertising to physicians. I mean, kickbacks are illegal, but advertisement is fine. I mean, especially if it's, called education, which these platforms often, call themselves. So I'd be interested in hearing any thoughts on what could be done about that. Okay. Thank you.
Great. Thank you so much, Sheryl. That was extremely helpful and a really good overview, especially I think that breakdown of kind of conceptualizing this on that, kind of integrated care versus this kind of fragmented standalone care. So next we're going to hear from Karen Palmer. So Karen, from what Sheryl said and kind of what we've seen throughout the pandemic, it's clear that there's this kind of growing interest from large corporations to get into the healthcare space, and they see clear opportunities for profits. Now, you and I have spoken about this previously, and I kind of love how you framed this in the past for me, that we'll kind of need to take a harm reduction approach to managing our relationships with these corporations going forward. I was wondering if you could expand about the current landscape of virtual care and what some of the policy implications are that CDM and our allies should be thinking about when it comes to virtual care.
I can sure give it a try. Thanks, Hasan. So I'm glad we're actually having this conversation so we can, begin to think together about the way forward with virtual care. I'll start by saying that my own thoughts on virtual care are still very much emerging. Unlike my well-defined positions in other areas of healthcare policy, virtual care is relatively new to me. So much of what I know is because I just finished working on a forthcoming report on the state of virtual care in Canada. And so what I offer is that I spend my days thinking about health policy and how to protect our healthcare system. I think we have to explore where we can live with commercial for-profit interests, where we cannot, and how to mitigate what we can't live with, essentially what you said, Hasan, the harm reduction piece. I do think that virtual care is here to stay. I think that the longstanding impediments, as Sheryl described, to virtual care basically evaporated within 2 weeks after the pandemic was declared, mostly because sectors, including the public, the for-profit and the not-for-profit sectors, found new ways to offer care, sometimes through collaboration and sometimes not. And so patients got some care and mostly didn't feel abandoned by their doctors. And I think this is a good thing, and it was enabled in part by virtual care. I think for-profit investor-owned companies are delivering, as we know, some aspects of that virtual care. And I suppose if we were to take the position that we should ban all for-profit ownership, would that mean, for example, that we would oppose the use of Zoom for virtual visits because it trades on the NASDAQ? You know, we know that the governments of BC and New Brunswick and Nova Scotia and the Northwest Territories and PEI all provided Zoom licenses to physicians. In Nunavut and Manitoba, those licenses were provided through Microsoft Teams, and in Alberta through Babylon's virtual visit service. And of course, those are publicly traded investor-owned corporations. I think it would be difficult to only support care delivered through government-owned corporations like the Ontario Telemedicine Network or through nonprofit entities when so much care is now delivered through corporate platforms like Zoom. You know, and what about investor-owned, for example, companies like AlayaCare, which allows caregivers to collect patient-reported outcomes and patient-reported experience measures, PREMs and PROMs, that can be shared with the patient's circle of care, or investor-owned Virtual Health, which enabled vaccination booking in Ontario, including through Unity, or investor-owned MindBeacon, which offers free therapy to Ontario residents and is available through employer-based supplemental insurance plans and employee assistance programs in other provinces. It doesn't seem like a great idea to oppose mental health services, even if imperfect, even if investor-owned, since I think we are about to see our collective grief emerge as our hypervigilance relaxes and we begin to process what we've been through. I think more people will need mental health support. So all of those investor-owned digital or virtual care companies, everything from Maple to Dialogue to Well, Babylon, Teladoc, Point Click Care, AlayaCare, Think Research, MindBeacon, Medeo, Tia Health, InSig, AdraCare, the list goes on. And some of those have joined forces with non-health companies like Loblaws and TELUS. They're all major providers or enablers of virtual care. And so they are now part of a mature industry and part of our healthcare ecosystem. And their combined market capitalization has been estimated at $20 billion or in that range. So they all extract profit. So what to do? Do we outright oppose all investor ownership, or do we have to figure out where to draw the line, the harm reduction piece? What I think the question we first must ask is, what do we value? I'm going to offer 4 things to consider. I think most would agree that the funding for care must remain public, and that speaks to the importance of the outcome of the Canby Surgeries trial and the appeal that's now underway, and that access must remain equitable. Governments moved quickly with new fee codes for these virtual care platforms, but some governments left out some modalities and the commercial sector stepped into that void. We can hardly blame them, but we should have anticipated that. Going forward, whether by phone or video or in-person or synchronous or asynchronous, we ought to say that care is care, irrespective of modality or provider type. If the fee schedules leave out services or modalities or provider types, for sure they're going to be profitized. So for example, some have raised concerns even about nurse practitioners charging privately in Nova Scotia because they can't apparently build a public system. So I think that any bits that are left out will become fair game for private pay. So if we don't make the new fee codes permanent, or if, for example, we don't fund asynchronous care like secure messaging through text and email, then those services will be provided for a fee, whether through direct to consumer or investor owned, high volume, sometimes virtual only facilities. I think this is a niche market in uncovered services. So I think allies should point out these gaps and call for their inclusion. I think our job is to watch like hawks for instances of inequitable access and be prepared to respond to government and to Health Canada. Next, I think continuity of care really matters to patients generally, but so does rapid access to care. So we have to get better at simultaneously providing both to minimize unnecessary trade-offs. Walk-in clinics, whether they're virtual or in person, exist in part because of failures in access to other parts of the system and in part because of rigged fee schedules. Digital triage services and standalone virtual only walk-in clinics may be good at access, but they often fail at continuity, as Sheryl so well described. Some say that there's no difference than calling 811 in its current form, since it also doesn't connect back to the patient's medical home. And as Sheryl and Tara wrote, we have to invest in and scale up models of primary care that integrate new technologies in ways that improve timeliness and convenience and also enhance continuity. Next, I think one of the greatest sources of inequitable access is still through our geography. We should be calling on governments to fix the digital divide to improve access to our rural and remote communities. And lastly, I don't actually think we can modernize our healthcare system without the innovations found in digital and virtual care. I think investor-owned virtual and digital tech companies are innovators. They look for gaps and they build for solutions. So with usable data, we can improve the healthcare system and support innovation, but we have to protect, again, as Sheryl said, patient data gathered in virtual care encounters just as much as, if not more than, we protect the data from in-person encounters. How do we do that? I don't know. This is not my area, but how do we protect from risks that Sheryl described, like targeted marketing? I do think we need thoughtful people from across the spectrum of people like us putting their minds to this, and we need to be invited to that table. I think I'll stop there, and I look forward to the rest of this discussion.
That's great, Karen. Thank you so much. So as Zarifa just mentioned in the chat, please feel free to type your questions in or raise your hand if you do want to ask a question of our speakers. I see that Melanie has one, so please feel free to chime in there, and we'll get to your questions as we go. So Melanie, why don't we turn it over to you and have you pose your question to our panelists.
Thank you so much, Karen and Sheryl, for what I think is probably the most clear explanation of the state of virtual care in Canada I've heard in a while. That really highlights the key issues in a really succinct way. My question is to expand a little bit more on what success would look like. So let's say CDM and all of our allies got together, we worked with the corporate for-profit driven virtual care platforms and created a system wherein all their different modalities are covered under publicly funded health plans. There is connectivity where the records are sent back to primary care physicians. Would that be enough? Do we think that that would be a good model to aim for virtual care in Canada? Are there any unanticipated problems? I'd love to get a good idea of where you experts think we can kind of aim so we can figure out where we need to go.
Go for it, Sheryl.
So I also think in order to achieve that, we need to make sure that everybody who wants one can have a primary care provider. And I think that's the more difficult piece of the puzzle. It's hard to figure out how to do it. The Price-Baker report, had a proposal and, it seemed fairly reasonable, but they didn't even get buy-in from the family health teams, for example. So how do we create that system where there's a primary care system where the physicians and the teams feel responsible for taking on patients in their area? I think that's a key portion of it, because unless we have that, then we're always going to have a significant number of people who attend walk-in clinics and who don't have access to virtual care except through standalone virtual care services, whether they're public or the commercial services. And yes, I think absolutely we need ways that these systems are integrated into the EMR, but also, to be honest, 90% at least of my well, maybe not 90, but I would say 60% of my communication with patients that's virtual is simply the phone call. Another large portion is email, which now we have integrated into our EMR, at least one direction. We don't get email back yet from patients, but there also needs to be a way to deal with that. And video occasionally, which is also integrated into an EMR. Before we used Zoom or other modalities like that, which I think is actually very different than using a commercial virtual care platform where the corporation is essentially delivering the care instead of providing a tool to providers. So I have much less of, even though Zoom is problematic, it's better now, but around privacy and security and that, but they're not actually retaining patient records. They're not billing patients outside of the healthcare system. They're providing a tool for physicians to communicate, like the telephone service, for example. So ensuring all those pieces are in place. Right now, I would say most team-based clinics, they have that integrated into their EMR if they want to do video or email. It's a lot of the fee-for-service independent practitioners that, they mostly use the phone too, but if they're using video, would probably use Zoom because they probably wouldn't have that. Some of them don't even have electronic medical records and probably don't have access to they can email a patient, they might not have access to secure email integrated into their EMR and things like that. Other things. So that and then prohibiting those harmful business practices. And I think Bill C-11 is a good start. I think it needs some tweaks. And I don't think it's going to get passed though, but it'll probably come up again, depending on who wins the next election. It will determine what format it comes back. And I'm not sure what to do about the advertisements within the EMR. I think that's extremely problematic, but I don't know how to address that. I'm not sure.
Karen, anything to add to that?
No, just, Mel's question was, would it be enough? I think it would be a start, but as Sheryl has pointed out, first everybody has to have access to care somehow. I do like what Sheryl just said. I like the idea of stratifying these entities into those that are tools to provide care and those that actually provide care. Like start figuring out what do we have a problem with and what don't we have a problem with? Which of these entities do we care that a company develops a very cool, undershirt that will monitor my heart? Is that a problem? Maybe not. Maybe that's a great thing. But that's a tool and not actually the provision of care. And so maybe we need to, right now it's just sort of this big clump virtual care. Maybe we need to start putting it into subgroups and saying, what are we okay with and what are we not?
Mm-hmm. Yeah, and actually on that point, Karen, you outlined a number of principles for us to consider, public funding, equitable access, rapid access, and continuity of care. Sheryl, I was wondering if you had any additional principles that you thought we should be considering as we go forward after hearing Karen's thoughts, or if you think that's kind of a good place to start.
Can you say those again?
So she mentioned public funding, equitable access, rapid access, and continuity of care.
So I guess I would go further. Yeah, I would say public delivery as much as possible, or at least not corporate delivery. I think it's still possible. I know we have these commercial players now that are, at least in some provinces, providing a lot of care. And regulation is one option, but regulation is also very challenging. Like you can see in the US, they have regulation, they have standards, and they still have a very expensive system that doesn't provide the same quality of care. So a way that we can pull the delivery as much as possible back into some kind of public system, or nonprofit kind of primary care system that has oversight over it. I think we have the ability to do it. We need the political will, some funds. It's not that the public system can't do it. It's that it just doesn't have the support to do it. it's kind of like, imagine our secondary care service, our system was like our primary care system, where, you know, a big chunk of the people didn't have access to hospitals or high quality hospitals. And then, you know, the private sector stepped in and started, you know, creating hospitals for these people. We'd say, great, wonderful. But, you know, the problem is the care there, from past experience studies, it's not going to be as good, and it's going to cost more. So what we really should be doing is still trying to push that public delivery of care as much as possible. But I'm fine, of course, you know, using tools developed by the private sector, because I mean, the health system isn't going to develop, you know, like AI or video chat programs, things like that. But then that's all over, like, it's not something that's held by these private entities. They don't control it. They don't control the data. We hire them. It's contracted out to them, where, you know, these people are hired to create these things. It's not just a simple principle, but I think as much as possible, like keeping for-profit corporations out of the delivery of care.
Maybe comment. Can you hear me, folks?
Yes, go ahead.
Michael.
So I'd like to provide an illustration of what Sheryl and Karen have both been talking about. I'm speaking to you from the Sunshine Coast, which is a short ferry ride from Vancouver. But we are, in fact, a geographical isolate, which allows for a kind of natural experiment to occur. So before the pandemic, 20% of the residents of the Sunshine Coast had no family doctor. Everybody has a family doctor now. And the reason that that has happened is to a large extent because of virtual care, and also because of the organization of the physicians themselves. A group of 4 or 5 physicians, one of whom is named Spithoff. I don't know whether he is a relative of yours.
That's my cousin.
Darren is your cousin. Well, Darren is one of the leads on this, and they did several things. First of all, they said that we will now see everybody, whether you are registered with us or not. They also provided, in the beginning, literally daily updates around the COVID issue, and now weekly still. They also established what they call the respiratory clinic, which means that anybody who has a symptom that could possibly be COVID is seen, and that clinic operates every day from early to late, 7 days a week, and they care for people. They triage them to the hospital if necessary, to Vancouver if they're really sick, and they now are, throughout the pandemic and still continuing, they are doing virtual care. There is no need for commercial care on the coast because everybody has a family doctor and everybody has access to a family doctor. The speed with which you get access is better now than before. The doctor calls back, you have a conversation, you find out whether you need to be seen or not, and business is taken care of. But the fundamental issue is that the doctors in this particular community, Darren and 4 others, even though they are fee-for-service doctors, behaved as if they were community physicians on salary. I mean, it's hard for me to get my mind around it. They actually took responsibility for the community and not the lucky patient who happened to walk through the door. And that has led to perhaps one of the lowest indices of COVID. We've gone weeks with no cases, or 1 or 2, and that's because not only did they take this on as a community effort, but they felt personally responsible for the community that they served, and the community felt cared for by these responsible physicians. And so the need for commercial virtual care, doesn't exist. So one of the interesting questions for them now, and I don't know how it's going to be resolved, is what will happen post-pandemic? And I think that what seems to be developing, as we are in effect a post-pandemic isolate right now, is that both the doctors and the patients like it this way. They like the fact that they have rapid access, and patients don't waste their time, and doctors don't waste their time, because as we all know, as practicing physicians seeing patients in the office, that perhaps, I'm picking a figure, perhaps 80% of the visits to a family doctor could easily have been handled by a phone call, and then a decision about what next was required. So it's a success story that speaks to the avoidance of the worst aspects of virtual care and enhances the best aspects of virtual care.
Can I ask a question?
Of course.
Michael, did they find that extra capacity then, that extra 20% of just time in a day, by seeing more patients virtually and needing less time to do that, and so they could take on that extra load?
For sure, that's exactly what happened. They and the care that they provide is more appropriate and more focused, and less time is wasted on things that neither the patient nor the doctor has any particular interest in.
So we are at the end of our hour, so we'll wrap up there. If you have further questions, please feel free to email us, and we will do our very best to answer and try and address any of the questions you have about virtual care. And just a reminder again, if you're a medical student, resident, or physician and not yet a CDM member, please consider joining so that we can continue to engage with you on really important topics concerning our public healthcare system, like the conversation we had tonight. So thank you again, everyone, and have a wonderful night.
Thank you very
Thank
much
you.
for all you do. Thank you.